Welcome, everyone, to the LifeBulb seminar series focused on organ transplantation. Today, we're going to talk about the future of transplant, which is a very exciting topic. And I'm really honored to have with me today Dr. Stern from NYU. My name is Karin Hienberger. I'm the president of LifeBulb, and I am myself a 3-time organ recipient, but also a trained physician and scientist. Really excited about this topic because for me, innovation is inspiration. And as someone who's living with an organ transplant, I always look, for the future and the improvements in science and technology that can make us improve our quality of life and, of course, extend the pool of organs that can be available for everyone waiting for a transplant. The reality is today, 20 people die every single day on the list, and even more are living in dialysis chairs every second day and not even on the transplant list. So welcome, Dr. Stern, and please introduce yourself, and then we can go into our topic.
Thank you. Thank you for having me. I'm Dr. Stern. I'm an abdominal transplant surgeon at NYU Langone Health and with our Transplant Institute. I focus predominantly on kidney transplantation in my clinical practice, as well as research in xenotransplantation, organ disparities, organ donation. So it's a little bit about my background, but I'm very happy to be here today and hopefully answer some of the questions and educate as we can.
Thank you. Thank you so much. And thank you for what you're doing. It is an area of medicine that is truly exciting. I've always thought that surgeons who are involved in transplantation are really unique because you do have to have that scientific education as well and the interest, because immunology is so critical to transplant. So not in contrast, because I do believe all medical doctors are interested in science, but especially transplant surgeons, you're doing these heroic surgeries, but then also you need to understand how to keep that organ alive for a very long time. During your career, if we can start there, have you seen any advance just during the years that you've been operating on people from a surgical perspective? And then we'll go on to the medical.
Yeah, I mean, absolutely. I think, we transplant physicians and transplant surgeons, I think in general, do carry that with us. Actually, studying immunology in medical schools was one of the things that solidified my interest in transplant surgery and my desire to kind of come into the field. I think there have been so many advances in our immunologic understanding of the human body and the immune process over the years. We've definitely seen lots of advances, some changes and advancements, specifically in the medications and our understanding of how the body responds to the human and how the graft responds to that as well. So I think, we've seen a lot of advances, and every year we discover new things that we can adapt and change how we treat.
So let's go into more detail there, because the reality is that we haven't had many new drugs approved. We had belatacept approved in 2011, I believe, but we're still using Prograf or tacrolimus and MMF or Cellcept, to a very high extent. And many transplant centers are still using steroids as well. So, those are pretty old drugs, yet you're saying there's been a lot of advance in the understanding, I guess, of immunology. I mean, I remember in medical school, we studied the mouse immune system, and we really didn't study the human immune system until very, recently, because we didn't have a good understanding. But now with some of the advances in autoimmune disease, such as multiple sclerosis and type 1 diabetes, I think we do have better understanding. But also, I think the research and the development in oncology, where we see a tremendous number of new drugs coming every year and truly changing the path for cancer patients, where many of them can be cured, from diseases where they just could not survive before. And in transplantation, we're hoping that wave is going to come and we'll get advances. So if we look at the surgical part of transplantation and how you do a kidney transplantation now, we're still operating with so-called, allografts, right? It could be a living donor or a diseased donor, but you mentioned xeno. What is that? Tell us a little bit more about it.
Yeah, absolutely. And, it certainly, yes, lots of advances in the medications. And as things have progressed, the 2011 and the belatacept kind of theory and how we are trying to minimize the calcineurin inhibitors, those introduction of the calcineurin inhibitors really changed the history of transplantation, and our graft survival and our outcomes improved significantly from that point. From a surgical technique perspective, we still do it almost the same way that Joseph Murray did it in 1954, and we still put it in the retroperitoneal space and still have 3 connections, an artery to the kidney, a vein away, and the ureter. The surgical techniques, based off of like a Corel patch and other things, those are all sort of the basics, and those have remained fairly unchanged, and even between the species. So xenotransplantation is the transfer of an organ or cells from one species to a different species. So one of the best target species to bring to humans is actually pigs, both because of their size, anatomic considerations, and hopefully reduction in or inability of viruses and infectious concerns to transfer kind of across the species. And so we look to those, and for the past somewhere between 20 and 45 years have looked to that species to adapt them to be able to look at those to be an unlimited supply of organs for humans.
These the pigs that you're using, are they the mini pigs or are they very large pigs? What kind of size pigs are being used for xeno?
Yeah, so there are multiple options on that. You can actually use full-size pigs, or you can use mini pigs. The organ, the kidney actually does adapt a little bit to the size. And as we are testing things in larger animal models, we think that we can take a smallish kidney and put it into a human, and the size actually shouldn't be too much of an issue. But yeah, mini pigs, they're essentially full size is that of a full-sized adult. So it's an intriguing possibility to use the smaller type pigs, although there are fortunately several companies trying to adapt pigs now, and some of them are on the mini-based model and some of them are on a larger pig-based model. But we've yet to actually elucidate whether that's a huge issue with the kidney.
But if you use a kidney from a big pig, that still fits within a regular-sized human?
Some of it depends on how big you let the pig get before you do the donation from the pig. So as long as it's small enough to physically sew in, it's probably going to be okay.
So tell us a little bit, because I think most people have read the press, right? You've seen in media, Dr. Montgomery, who's at NYU, has been doing, and you, part of the team, you've been doing some really interesting things, as well as up at MGH. And so we've heard about these stories. So tell us where we are with xeno now. Is it a reality? Are patients getting this opportunity? And if so, what kind of patients?
Yeah, so I think we're right on the cusp now. I've been very fortunate to, at the end of my fellowship and, as an early attending, be very intimately involved in all of our decedent work, which is our brain dead whole body organ donors, where we're testing transplants into brain dead humans who have donated their body specifically for that project and for that study. And so we've done that about 5 times now, where we've looked at it: 2 early kidneys where we monitored them short term, 2 heart transplants actually after that, and then a very long term kidney study for about 2 months. We watched the kidney in the decedent. And so, our thoughts and kind of where we are in the field is to test those out in a model that we can look at what the human immune response is to the kidney, to make sure that there are a lot of the functions of the pig kidney in the human that can be monitored and watched, and make sure that the trans species effects are okay for future human trials. The MGH patient and our patient after those initial studies were very sick kidney patients that really didn't meet criteria for normal transplantation. The MGH patient had very significant antibodies and some vascular disease, to my knowledge. I don't know all of the individual details about him, but received a xeno kidney transplant, which lasted for a little over a month, I think is what the dates are. And then our patient, which I can give obviously no more details on, was not a candidate for either a heart or a kidney or a combined organ transplant due to multiple medical comorbidities. And so we offered her a combined heart pump assist device, a left ventricular assist device, and a xeno kidney transplant. And so, the current patients that we can offer xenotransplant to are single patient approvals from the FDA currently. And they are really patients that are not otherwise a candidate for an allo kidney transplantation. So we're really out of the realm and really providing last ditch efforts to those patients. The hope is within not too long a period of time that we can establish the criteria for patients to be included into a clinical trial for xenotransplantation. The hope is that that's not too far off or too far-fetched to be going in that direction fairly soon. My hope is within sort of the 12 to 24 month period of time that we would be headed in that direction.
That's really exciting. That's truly exciting. Going back to the statistics of the 20 people waiting or 20 people dying, every day on the list, and so many people, getting dialysis and not even being accepted on the list. There's a big opportunity, of course, for Xeno to help those patients live longer and have a better quality of life. So that's exciting. When it comes to drugs, you mentioned that there have been advances in immunology, a better understanding of so-called tolerance and immune modulation, belatacept being a development from maybe the CNI. What do you see here that could benefit? Because as patients, we hear a lot about the side effects. Number one, of course, the issues of kidney injury due to CNI and pancreas injury due to CNI, that it affects the duration of the organ, but also the tremors, the headaches, the hypertension, the diabetes, and there's so many side effects, GI issues. What do you see coming in the near future or soon, hopefully?
Yeah, I think you're exactly right. The CNIs were really this blessing and the curse. They provided early survival, but they've always been the limitation of really long-term sort of kidney function. And so being able to minimize the side effect profiles of CNIs or even reduce doses in combination with the belatacept therapy allows for decreased toxicity of the CNI while maintaining kind of a decreased rejection potential. There are a couple scenarios where avoiding CNIs altogether, can be achieved. And some of the newer drugs and medications that are being developed by companies. We mentioned before companies that are producing drugs on a monthly basis for cancer. Unfortunately, transplantation medications have always sort of been in this back seat. There are a lot of patients who need organs and need immunosuppression, but there are many more patients that need oncology drugs and cancer treatments. And so transplant in general has adapted a lot of those medications, or we take advantage of the sort of side portions of those medications and use them in transplant. So rituximab being one of those, a cancer medication that we actually use to reduce and block B-cell maturation and antibody production. As we advance, there are some transplant-specific medications. So co-stimulation blockade, or as we look to the future, there are several medications in the pipeline that we're very hopeful for that can block sort of a second immune response to the kidney that we can really block to prevent rejection in the future. And that would allow for hopefully total CNI avoidance for kidneys. And there are several trials ongoing for that. And I think we're all optimistic and hopeful that day of total CNI avoidance is possible. We've also, I think, as we've increased the understanding of the immunologic matching and a little bit more fine-tuned, if we look at what are called eplets.
What are eplets?
Kind of have an analogy for eplets, and I don't know if it's a perfect analogy, but it's a way that I like to explain it because it was a way that was explained to me, but it's sort of a surrogate, which is sort of the HLA matching is, if you look at the United States and you look at different cities, it's are you in the same city as someone else, or are you in New York, or are you in Boston, or how far apart are you from your major matching episodes? And eplets was described to me as, if we're both in New York City, are we on opposite sides of Manhattan, or are we actually in the same building in Manhattan? Are we just different offices away? And so how, at the very small level, are we immunologically matched to each other? And the thought is that if we're in the same building in Manhattan and we're just a couple offices away, we're going to be together and we're not going to have other things react to us. So the immunologic matching of where we are is a little bit closer. And so our chance of rejection, or the thought that our body will develop an immune response to that organ or to the cells of that organ, is much lower.
And can we do this already? Can we do this already, the eplet matching?
Yeah, so eplet matching is something we're doing very routinely, especially on all of our living donor kidney transplants, where we can plan ahead of time and look at the matching between the donor and recipient. And even actually now through kidney swapping programs, we can have patients not get the organ directly from their intended living donor, but actually do a swap to decrease the mismatch between the donor and recipient.
You're saying that even if a person has a living donor who is a relative, there could be a closer match with someone who is not a relative when it comes to eplet matching.
That is exactly correct. So sometimes we think it's actually much more advantageous to get a better matched kidney from someone who's not their direct relative or a friend or whoever, because hopefully we can reduce their immunosuppression in a long time, or do these steroid minimization protocols, or several actually clinical trials right now to try to sort of look at that, study the long-term effects. Our thought is that, the rejection risk is lower with a lower eplet mismatch is what we call it.
That's really interesting. So anyone who's looking into a living donation and should be asking their transplant center if they do eplet matching to make sure. If the eplet matching is not perfect between two siblings, for example, is there something you can do beyond the swapping?
Yeah, I mean, there's lots that we can do there as well. And there's some other trials that actually look at tolerance induction, or even potentially combined bone marrow and kidney transplantation trials that look at being able to withdraw immunosuppression entirely in some of these places. So there's a large spectrum of things that we can do, especially I think, for those listening to this, if you need a kidney transplant and you have anyone that could donate, it really doesn't matter anymore if you're blood type compatible or even an immunologic match. We have so many options with the swapping programs that are now available, that the fact that you have someone that can come forward as a living donor really increases your ability to get a well-matched transplant through one of these
That's
programs.
remarkable. So as long as you have someone who will give a kidney, then you might be able to bring that person into the system, and there could be extensive testing on both sides, and then that donor can be matched to the best eplet matched recipient, and you as a recipient could get a kidney from someone else who's better matched, and both would benefit. And that's just a two-way swap, but there could be many swaps in a chain where you could obtain or achieve really good match.
Exactly. This is one of sort of the great things of humanity, is that you don't just benefit from this, but when you bring your donor in, everyone kind of benefits and gets a better kidney out of it. Is the hope, is that the utility across the whole board is better. Yeah, absolutely.
That's wonderful. That's great. You were talking about tolerance and about trials that are ongoing where you would also use bone marrow. You would do a bone marrow transplant from your recipient, and then you would also get the kidney from that recipient to kind of reset your immune system. So the process would be a two-step there in that trial?
Yeah, so there are several ways of doing this. This was actually discovered sort of in cows a long time, and the person who discovered this won the Nobel Prize, for discovering sort of mixed chimerism and the immunologic basis of this. And so lots of people are studying this, and there are a couple different methods of doing it. But as long as sort of the match is okay and the way this process works, you can either get a bone marrow transplant ahead of time and then a kidney transplant from the same donor, or you can actually do it later on. So you can, if you're a good match, you can get your kidney transplant, and then later on, the donor can donate the bone marrow to try to induce the tolerance and engraft the bone marrow, and then reduce the immunosuppression.
I didn't know about the reverse timing, that you could also do the bone marrow afterwards. That's interesting. I'd heard about the bone marrow transplant followed by the kidney, but I didn't know you could reverse it as well. That's interesting. All these...
delayed induction of tolerance.
Delayed induction of tolerance. Okay. Do you know if there is a site somewhere where it describes all the trials that are ongoing for organ transplantation?
Yeah, I think on transplant.gov, I think you can look at all of the trials, across the board, all NIH approved, clinical trials. The transplant specific one, I'm not currently aware of that. I don't know if you have.
Oh, you mean clinicaltrials.gov? Yeah.
Oh, yeah, that's what I meant.
Yeah. But that's very hard to maneuver. I think it's hard to maneuver for a scientist. It's very hard to maneuver for. There's a real, and maybe this is something that we at Transplant Life should take on, but there should be a place for where all the trials in transplant are, so patients could actually find it. We do on Transplant Life with a Y, we do have certain trials that are there, and we encourage patients to go and also to connect with other patients. But we do have a special section dedicated to clinical trials. But it would be really interesting to showcase a large number of them.
That's great. I think that would be a great resource for patients.
Yeah. And also maybe for physicians, you if you see a patient and you might not have the clinical trial available for them at your specific center, you might be able to send them to another center, because obviously the patient's benefit is what we're all seeking. We've talked about Xeno, we've talked about the new drugs, we've talked about eplet matching. When it comes to diagnostics and making sure that we detect anything that could go wrong, meaning rejection, which is a big fear with many patients. Anything you have seen there that is maybe not done everywhere, but is at the forefront right now?
Yeah, certainly there are many physical biopsy improvements, both sort of AI interpretation of the biopsies, so that there's a more sort of standardized pathologic approach and looking at specific cells and a much more in-depth staining that has really improved over the last decade to get a better sense of what is happening within the kidney, as well as cell-free DNA technologies and sort of looking at differential gene expression, both in the cell-free and in the biopsy themselves, to point us towards what the diagnosis is and what therapies we need to undergo from what's going on. But yeah, one of the potentially predictive things and long-term monitoring is some of these cell-free DNA technologies that we do for many of our patients.
That's great. And that would avoid some biopsies that, can be a little painful. And also, of course, always any biopsy has a risk of bleed, even though it's very small, but still there's a small risk of having a complication. That could be comforting for patients to see if there's a rejection ongoing, and then there will be a need for a biopsy.
If we change the therapeutics, how does that number change over time? And kind of, did we settle things out, or do we then need to go down that dichotomy of biopsy or no biopsy? It's very helpful in that process.
So you mentioned before that there were many more patients who were cancer patients versus transplant patients, but we have 250,000 kidney transplant patients walking around, right? We have 25,000 every year and about 44,000 organ transplants every year in the US. So it's not insignificant. And in certain cancer areas, there are even fewer. I do think there's a need for the community to kind of stand together and say we want better drugs. It's really, I think all transplant recipients share, toward their donors, toward their surgeons and their nephrologist or cardiologist and whoever is treating them. But still, we have not seen progress at the same level as maybe in other, therapeutic areas. What would you say to our patient community to try to help you as a scientist and as a medical doctor to kind of progress the field, get the FDA to, expedite pathways, get young medical doctors and young scientists to work on, new treatments, start new companies, encouragement to this patient community?
I mean, be present and be vocal for all of these things. In many ways, I feel like in the world where we are, the loudest voice wins, right? And if we don't have a voice, it doesn't matter how small of a group you are, the louder your voice is and the louder we talk about our needs and our appreciation for donation of organs, both from deceased and living donors, to make them last as long as possible. It's an urgent need every day that we need more people and more minds in this field to make this all successful. The more impetus we have for that, and hearing patients' voices is really powerful. Actually, most recently at one of our national meetings, we had a patient who received one of the first successful liver transplants come and speak to a group of surgeons. And it is one of the most powerful messages that we as surgeons and physicians in transplantation can hear, is the patient's voice and that drive. It's why I come to work every day, because I like to see the happy faces after transplant every day. That's what keeps me going. That's what drives us forward kind of every day, is getting to work with transplant patients. Where, I went into transplant not to, high five at 5 years because you're cancer free. It's to high five at 20 years when your kidney is doing great. That's our goal. That's the holy grail of everything that we're doing. And whether that's allotransplantation, immunosuppression minimization, tolerance trials, or hopefully xenotransplantation one day, our goal is to prevent you from going on dialysis altogether or take you off dialysis if you're on dialysis, and really kind of get you back to the life that you want to live.
That's beautiful. And that's exactly aligned with, our view. I think that the best thing we can do for our donors who have given up an organ, given us a new chance to life, is number one, to be truly happy, right? To truly try to enjoy every moment. And to do so, we need a great quality of life. We need to feel good. And, for that, we need development in drugs. We need drugs that do not cause side effects. And to extend the life of the organ, we also need great drugs and good matching so that we can continue to thrive, with that organ that has been given to us from someone who may be alive or is diseased or maybe, coming from a pig in the future. But, it doesn't matter where it comes from. We have almost an obligation to enjoy, and to be present. So I thank you for everything you do. And I really appreciate this conversation very, very much. And I also want to thank ITB Med for sponsoring this series. It's really important that we can share with patients words from, great surgeons and scientists like yourself. So much more to come, but thank you for today.
Thank you for having me.